this is I've never had such a tremendous interest in coming to a seminar about this program. So I'm assuming a lot of you are, initiated by what's going on in the political environment. So it's going to really affect you, what's happening. Some of the things I'm going to target today to talk about, you'll see why it's going to be affecting you and how it's going to be affecting you. I'm going to try to keep the discussion to about 1 hour. But if everybody had a 2-minute question, we'd be here a few hours just answering questions, right? So I'll kind of abridge that procedure, and I'll show you how we're going to do that as we go along. In your handbook, I provided some materials. Everything I'm going to go over is in your handbook that you all got, right? And there's a record number that we all gave you in the front of the book. That record number is really important because of a few things. First of all, under federal law, I have to protect your privacy, so I don't want to use your name or anything to identify you other than number. And that's why we give you the record number. The second thing is that I have to be compliant with CMS regulations. And part of that compliance is that in the back of the book, anything that you want to talk about directly, you have to sign what's called a scope of appointment. And I'll explain how that works later. But the scope of appointment essentially outlines what you want to talk about so that when I talk to you, I'm only going to talk about that subject matter. All right? So under Medicare rules, I can only talk about things that you want to talk about, not what I want to talk about. Okay? You got that. That's the rules.
George, wait, you don't get to talk yet. I lowered it. Is it better?
That's perfect.
Okay, thank you.
Thank you. And I know everybody's... Yes, sir.
I have a record number.
You need a record number. Hey, Devin.
What's his last name? Ratziminsky. Okay, let me find out.
You'll get it for you.
Yes.
I know everybody's situation is unique, and you probably came here with questions about things that are applying to you. So in that environment, I can't discuss it publicly, and hence, I generated what's called a questionnaire form. It's in the back of your document here. So things that are specific to you, we'll write them down, and then I'll get those answers for you if I don't have them immediately, and I'll get them directly to you. But under the rules, I can't discuss them in an open forum. But I can discuss generalities if you like.
There you go. Right over there. This, no, which side? Hello? Hello? Right here. No. The other
Second
side.
page. Here's the most important statement I'm going to make to you. CMS prohibits me from requiring you to provide contact information, so you must provide your contact information so that I can contact you and address your questions and deliver information that you requested. In other words, I can give you information, but if you need a question answered, I can't go to you unless you say, go to me. Follow that? That's a very important rule. Because even though I want to get you the information you want, I can't do it unless you authorize me to do so. They're all part of the rules. I'm also going to limit my discussion to Medicare plans and issues related to Suffolk and Nassau County. Maybe some of you from Staten Island or wherever. This is really for Suffolk and Nassau counties. I can address those issues, but because we're all in Suffolk County, because we're all in Suffolk and close to Nassau, I'm going to try to limit the discussion because there's a lot of content in that area. Here's some of the do's and don'ts under the CMS rules. Let me just go to those. A lot of rules. Hey, Brandon. Where'd Brandon go?
Brandon.
Brandon.
It's not clicking
What?
forward.
Pen? Catholic. What's the last name? Catholic.
Technology.
Oh, he's doing that. I got a question.
Sure.
This is called Medicare Advantage. What's the difference between that and PPO?
Good question. I'm going to address that for you as we get through here.
Okay.
All right? You working? Once you forward, fine. Well, anyway, some of the do's and don'ts under the Medicare rules. This is considered a formal event, not an educational event. So we can talk about like types of products that you may want to purchase and so forth. No food's permitted to be offered. That's why we can only give you a voucher to go at Starbucks. Just want to make that clear. Only one product can be discussed. I can't compare your product against another product. That's against the rules. But in generalities, I can. But if you have like product X and you want to know how it compares against product Y, I can't do that in this forum. It's against the rules. You follow that? Like I can't say a Chevy and a Ford. What's the difference between the two?
Can I find out if it's covered in Florida?
I can't answer that.
Where can I get the information that you're not covered?
We're going to write it down, and I'm going to give it to you outside this forum. Okay? It's a very confusing rule because Medicare doesn't want me to sit here and say brand X is better than brand B. That's really what it comes down to. I can whisper it outside, right? I also can't discuss products outside the area of Medicare Advantage and Medicare products. So in other words, estate planning or tax matters that affect your medical insurance, I can't discuss them simultaneously. Too many rules, right? Who needs all this? Let's see. Cannot discuss any subjects out of the scope of appointment, which we discussed before. And I have to use standardized language developed by CMS like zero plan premium, which is just another way of saying you don't pay anything, but I can't say that. I have to call it zero plan premium. You understand that? That's an important one because you may ask a question, I might try to give you an answer in standard language. It may not make sense to you. Like zero plan premium, what does that mean? It's free, right? I can't say it's free. Zero plan premium. That's the rules. All right, I think that's enough of those rules. On to me. I'm just going to give you a little background. This is a brief synopsis of my background. I have a degree in business from SUNY. I graduated as a CFP from the College of Financial Planning in Denver. I hold insurance licenses and brokerage licenses in all 50 states of the Union, including Hawaii and Alaska, which I've never actually been to. I'm also licensed as a property casualty agent. I own the Series 6 and 73 in securities business. I'm a certified flood underwriter for FEMA. How appropriate today, right? And I currently maintain an LUTCF designation. Basically, it's like a master's degree in life insurance. So I have a very diverse background in insurance. I've been in it over 25 years. But I'm only going to discuss Medicare-related products today because I can't do anything other than that. Okay? Moving on.
Yeah, he probably has it.
What? Yeah, whatever. Just make you do it. Make it work. Okay. Hit the button. Right. Okay. Left. Right. Oh, wait. Just to give you some background again, I have over 20 years of experience in the Medicare Advantage, Medicare Supplement, Medicare Select, which we don't have around here, Final Expense, Part D. I started with a Medicare company, Mutual Beaumont, everybody knows that company. I started with them many years ago. And they're the leaders in Medicare products when we first started. But I'm also considered an expert nationally in COBRA in law and insurance and regulations. Why is that? Because when you retire at 65, you usually take COBRA. So about 20 years ago, I started a company related to COBRA laws. So anything related to those people who are turning 65, maybe retiring, considering COBRA, I'll be able to help you with that. I am considered, pat me on the back, a national expert in COBRA law and regulation. I also like investments and all that other kind of stuff. It's all on your package, so you can see about what's going on there. All right, so let's get started. What I'm going to do today, I don't know how many of people are turning 65 or entering the Medicare system and already in the system. Let's see, you all look too young to be in Medicare. I don't know why you're here. Why? But I'm going to basically go over the changes that I identified in my daily research that I have to contain, do for my position, understanding Medicare and how it's going to affect you. But then I'm going to go into when you turn 65, what happens. So the stuff I'm going to address now will affect you if you're going to be 65 entering Medicare in this year. It may not be in the system today. Everybody understand that? Okay, good. So first thing I'm going to go over are some of the major changes that occurred for 2013 in the Medicare system. If you enter the Medicare system in 2013, this will affect you. The first and most important thing is that your physician's fees and schedules are set to change. They're going to get paid more, actually almost 7% more for, this is the important part, for general practice, internists, guys who take care of the day-to-day trench warfare in medicine. Those guys are going to get paid more, up to 7% more. And that's good for you, because as you see as we go through this information, the new model for healthcare under the Affordable Care Act and Obama and Obamacare and all that kind of stuff is really gearing away from what it used to be, which is specialized medicine. Remember years ago, everyone wanted to be a specialist, brain surgeon, podiatrist, whatever. They want to get away from that. When you read all the legislation, what they're doing, they want to bring you back to the family doctor. Remember the guy that when you were a kid? You know, you knew your doctor. I still remember my family, Dr. Tooman. Everybody know that guy? He's from here. Anyway, that's what they want to get back to. So they're going to pay more to the local guy, the day-to-day guy. And they're going to actually cut funding for specialists, you know, the heart surgeon, the cardiologist, and so forth. So you can read here, much of the increase in the physician fee schedule reimbursement will come from added payments. That's just code for we want you to do more for the same, right? In following a patient's care 30 days following their discharge from a hospital. So what the whole process that they're trying to get to have happen here is you go to the hospital, you get sick. Get out of the hospital. Remember, you never heard from your doctor after you left the emergency room? Now you're going to hear from him literally every day. Because every day he calls you, he's going to get paid for that, action. Prior to this, when your doctor called you, he was just doing this because he was a good guy, or he wanted to follow up, he was interested, or whatever. He didn't get paid to make a call to you. Now, there's actually something called a DRG. Everybody familiar with DRGs? Okay, good. One. Anybody else? I'll explain DRGs in a second. But DRGs are like a code that translates to how much I get paid for something. There's actually going to be a DRG for, hey, I made a phone call to Mary after she got discharged from the hospital to see how she's doing. That never occurred before. That's all in the new legislation. So the AMA, of course, comes out and says, and this is the director of the AMA, right here, AMA president, thank you, goes, we appreciate CMS recognizing the value of these services for improving overall quality of health. As this rule supports physicians working in emerging models of care, that's just, new speak for it, we're going to change it up, and the work involved in transitioning patients from one care setting to the next. What does that mean? Get out of the hospital, go home, right? But the cardiologists are like, wait a minute, you're cutting fees to us, we're going to get killed. We're dying over here. So, of course, the guy who runs this cardiologist group, he's like, this healthcare delivery is unsustainable. So you have two of these camps, the everyday physician and the specialist who are going to compete now. And you're going to probably see a lot of cardiologists become internists. Like my cardiologist is an internist as well, so he's going that direction, right? The second thing is that another final issue rule under the law is that Medicaid reimbursement will be brought on par with Medicare primary care reimbursement. What does that mean? That's just, I don't know, political speak, whatever we term it, that prior to this, if you were a Medicaid doctor, you got paid here, and if you're a Medicare doctor, you got paid here, and if you're a commercial doctor, you got paid here, right? So what they're trying to do is merge Medicare and Medicaid to become par with each other, which is kind of weird because Medicaid is funded by the federal government. They give a block grant to the state. The state says, okay, we spend it. If we spend more, it comes out of your tax dollars, and they always spend more, right? Who spends less? Now, the federal government's saying, if your Medicaid payments are here and Medicare payments are there, we'll make up the difference. They're going to bring it on par. What does that tell you? They're telegraphing some information to you. Do you know what it is? We're going to merge the two systems at some point. If the payment for Medicare and the payment for Medicaid are the same, why have two systems? Just merge them. And that's what this is really telling you, in my opinion, that they're saying over time we're going to merge the two systems. It will no longer be Medicaid, Medicare. It'll just be all one system. So it says right here, the federal government will pay 100% of the difference between Medicaid state plan payments and Medicare rate. You're going to merge them. Next one. Oh, where'd he go? Ran it?
He did it.
Oh. Okay. These payments go into effect in January 1, and CMS and states will work together to make these payments operational. So basically, it's going to happen January 1, and now that you have a new president, for whatever your beliefs are, that's going to stick because the challenge to Obamacare goes away now. It doesn't really exist anymore because there's no one to challenge it. It's stuck because the implementation starts in 2014. If you ever seen the whole timeline, you can see it from when it was originally passed to when Obama goes out of office. It really started in his second term, right? That first stuff was just fluff. Going to cover your kids until 26. That wasn't because they wanted, that's to get you to buy in. It's really starting in 2014. The exchanges go into effect in 2014. You're very familiar with the exchange stuff. It's an off-topic subject. I can talk that later. Also, preventative services will continue into 2013 with no deductible, no co-insurance. What does that tell you? More prevention, primary care, that's the key word, primary care. Everything in the Affordable Care Act, Medicare, it's all going to primary care to keep you healthier, and when you get sick, to get you better faster, and keep you out of the hospital longer. Because the primary way they're going to do it is they're going to pay your doctor to deliver care to you when you need it after you discharge. Yes, sir?
You won't have cardiology.
That's exactly right.
Deliver that.
Well, that's a good question. I don't know. I mean, those are bigger questions than I can answer. But you're right, because doctors are a business. Yes, sir?
I just arrived.
Yes, sir?
Is this what you're doing on there?
True.
Now, what page?
We're on page 11.
Page 11?
Right. Page 9, I'm sorry.
9?
Page 9. Yes, sir.
Where are we?
Why didn't you get here on time?
Page 8. No, page 8. Oh, yeah.
Page 8.
No.
All right.
All right, don't get rambunctious. So as you read through all this stuff, and I've read a lot of it, I've read the Affordable Care Act, what I needed to read of it, voluminous, and everything in Medicare, because that's my business. You can see it. You can just understand after you read it and put it all together. No longer are your physicians going to specialize. They're all going back to primary care because that's what they're going to pay for. And more importantly, the government's going to make sure they get paid to call you and make sure you get better after you get out of the hospital for at least 30 days. They never did that before. That is a huge change. Yes, sir? That's a good one. See? Because if I was a physician, right, I would get a nurse practitioner who I'm paying a third of the cost. It doesn't matter if I sign or he signs. We're both legally licensed, right? You get a nurse practitioner, and hey, how you doing? I'm calling for Dr. Smith. You know, bingo. He still gets the DRG rate. Let me go back to DRGs. Let me explain it. Brandon, can I pull up something on my laptop here and show it there? No? Okay. Let me explain the DRG. There's some documents I want to go over on here. Okay, do it on your phone. Okay, DRGs are simply this. They're called a diagnostic related group. Essentially what it means is like everything that goes wrong with you, doesn't matter if you got a cold, a sniffle, a broken arm, a twisted toe, whatever, there's a code for it. And they match that against what's called the CPT code. Hey, Mitch, the CPT code, that's the diagnostic. You must be a medicine because you're right with me. Okay. Yeah. So it's like a car mechanic. Like you take your car to the mechanic and you say, I have a squeak over it. He goes, no problem. He opens up the book. Okay, I can fix that. It's $84.95. Right? It's the same thing in medicine. Medicine is mechanics. We have a condition, we have a treatment. The condition is diagnosed, they apply the DRG, and that's how they get paid. You can't get paid without a condition and a diagnosis and a treatment, right? Prior to this, no treatment for, hey, how you doing? Following up with you. Now they got that. It sounds like a minor thing. It's billions of dollars. Right. It's a lot of money. The other thing, now in the beginning slide, I told you doctors' payments are going up by 7%. Well, under the fiscal cliff and all that other nonsense, they're actually going to slash their payments under Medicare 27% come January 1, right? This Congress acts to change that. Why would they do that, right? So they give them 7, they cut 27, it's a net loss of 20, and they're going to bring Medicaid up. So if you bring Medicare down, Medicaid up, it's not so bad, right? And then you have the merger of the two plans, and before you know it, you have one unified health system. It's like a new world order, right? Conspiratorial. You think it'll work? Oh, okay. So in the end, what's really going to happen for you when you enter into Medicare in 2013 is you're going to hear from your doctor more often, and your costs and deductibles are going to go up over time, actually over into 2020, which is all part of the Affordable Care Act. Well, your costs are going to creep up on you. It's like a snake in the night. When you don't see it coming, one little thing at a time, and all of a sudden, whoa, it's there, right? And one of the documents, let me pull up one of these documents here, I'll read it to you. It's really fascinating. We got it here. All this technology, Brandon, I can't do anything. Hold on, the technology wizard is working here. Now I want to go to one of my files up here. This stuff fascinating, I love it. Reference to Israel. Yeah, only one works. 2013, right here. Okay, stop, go away. Okay. So I'm reading, anybody know what the Heritage Foundation is? It's like a think tank. So, here's what they came up with. After they analyzed all the stuff going on in the Medicare trustees and all such, it says 2012 Medicare trustees report says that over the period of 2012 to 2017, which really coincides with all the implementation of what? Affordable Care Act, Obamacare, right? Senior standard Medicare Part B monthly premium will jump from $99.90, which is what it is now, forecasted to be, didn't put it in your brochure because they didn't have it, $109. It's going to go up $2, right? It's going to jump from $99.90 to $128.20, while their Part B deductible will rise from $140 to $180. Nickels, dimes, nickels. Over the mass of people in the Medicare, it's billions of dollars, right? So, blah, 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 blah. The Part A deductible, which I'm going to address later on, is going to rise from $1,156 to $1,336. This all doesn't sound so bad when you apply it to you, right? A couple $100 here, $10 there. It's billions and billions of dollars that they're really working with. Their daily hospital co-insurance will climb. This is one of the things we're going to go over later. From the $289 a day co-payment or co-insurance it is now, to $334. And the senior in a hospital beyond the 90-day lifetime reserve will pay $668 by 2017. These aren't big numbers, right, on an individual basis, but on a scale of the aging baby, you're all baby boomers, aren't you? All right. As you age into the Medicare system and you translate this to the overall budgetary impact, it's a lot of money. Here it says, and this is their summation in their thing. In other words, under current law, anyone over 65 who fails to buy private catastrophic insurance is taking a huge risk, and that's true. I'm going to show you that as we go along here. Let's go back to this. Can you go back one screen, Brent? Got it. So let's go back to this. Your preventative care, which again, thinking about how they're telegraphing what they want you to do, under Medicare, all your preventative care will continue with no deductible, no co-insurance. So when you enter Medicare, turn 65, in the first 12 months, you get a free exam. It's what we call a health, or HRA, right? Health assessment, essentially. They want you to get 65, get assessed in your first year, get a baseline, and then they pay for your annual Medicare preventative visits once a year, and they do all these types of procedures for you, like coma, colon rectal cancer screening, bone mass. I love this one, alcohol misuse. You know what I mean? What are you doing on your day off, right? Depression screening, drinking. You know, diabetes, that's a big one. Diabetes screening. HIV screening. Right? Nutrition therapy and services, you need to eat more, better. And obesity screening. So all these, next screen please. And they're going to give you flu shots. That's why every drugstore you see, come and get your flu shot. Drugstore, really? They're paying for that. They want you to stay healthy. It's really good when you think about it. I mean, years ago, like, you get sick, then I'll treat you, right? Now they're like, stay healthy, we'll treat you. But it just costs a lot of money. That's what it boils down to. We're also going to do this. This is a fascinating one. Here in 2013, the hospital value-based purchasing program will distribute an estimated $850 million to hospitals based on their overall performance on a set of quality measures. Keep that in mind. Keep the word quality measures in your head. That's how they assess the hospital and how it's doing. Is it a good hospital? Is it a bad hospital? And that type of mindset translates directly into another product, which we're going to discuss today, Medicare Advantage plans. I'm going to show you how it works. So quality measures and your satisfaction. So are you going to be satisfied when you get out of the hospital? Dr. Smith, hey, how you doing? Feeling okay? You're going to be, my doctor cares. You're going to give me like, just like when you bought a new car, they say, can you give me the, they give you a survey? How was your dealership experience? 5. The dealer gets $5,000 bonus. Lousy. Nothing. Same thing over here. Assess your doctor's performance and how he's doing. And the fund's going to generally increase over time, resulting in a shift from payments based on volume to payments based on performance. Is that a good thing? Yeah, it's a good thing. You want your doctor to care. He's a businessman, just like you are. He's got to get paid for his time. He doesn't sit at the phone at night. How you doing? He wants to do that. He wants to make a living too. Next slide, please. Okay, you can read all this. And you can find more information at your friendlyhealthcare.gov website. I gave you that. Just click on that hyperlink, go there, you can spend hours reading all this good stuff. So what's the takeaway for 2012 and beyond? I'm going to read you a few more things here. Kind of summation of all that information right here. Hold on a second. Oh, I got to show you this one here. Continuing with the thought of 2013, the government wants your primary guy to take better care of you. If you are a specialist in 2013 and you're, say, for example, a cardiac surgeon, Medicare is going to cut your reimbursement for procedures 2%. If you're a, let's see, an anesthesiologist, the guy who puts you to sleep so you don't know what's going on,
More important, the other way, Joe.
3% loss. Interventional radiologist, these are all specialist guys, 3% off the thing. Nuclear medicine, 3% cut. Here's a big one, radiation oncology. Kidding me, right? 14%. Chopping 14% off what they pay these guys at the Medicare rate. It's not even what he normally charges. He charges, $1,000. Medicare says, we reprice it to $50, and now we take 14. You know what I mean? They're taking it all away. They want you to become a primary doctor and work on an Indian reservation in Nebraska. I don't know, maybe go on like medical vacation to India where the guys are like
going to Russia and getting better medical.
It's funny, I hear that all the time, like with better medical. They're coming here. They're coming here for medical care. Right. And it's the odd thing, everybody watch Current TV? I was watching Current TV on medical vacations. People are going to India for knee replacement and stuff. It's less expensive, but they have to wait, all right, whatever. The answer is, I don't know what the answer is. I'm a facts guy, I just read it and absorb it and think about it. But I can tell you, if I was going into medicine, I'd really think hard about where am I going with this? Because this is here to stay. It's not going away because, they're not going to repeal it. It's all going to stay now. It's like a nuclear reactor. They sort of got it dirty, like when they did Shoreham at 2%, then they run it up to like 2%. Oh, it's radioactive. What are we going to do now? Same thing.
The plan provide money for those specialists to go back to school so they could.
That's a good idea, but I didn't read anything in the literature that said that, like, we'll retrain you. No, nothing. So, but here's the thing that I thought was really fascinating. All these guys are getting cut, right? Right. All these guys are getting whacked, and
That's only certain specialists, is that correct?
everybody is in a specialty. You're seeing a reduction. But internal medicine guy, 5% increase. Right. Family practice, 7% increase. So they want you to become a primary care doctor. Maybe become a primary care doctor and cardiologist. Or, yes.
Sorry, I just have a different perspective on what you're saying.
Yeah.
And what I'm seeing is that not that they're cutting the specialists and giving more to the primary care, but they're bumping up the primary care because they want people to go to their primary care physician for preventative services.
Right.
And so
Exactly.
that's why they're getting the increase. It's not because we're looking to punish the specialists. And the other thing too is the DRGs are on their way out. That value-based program is your pay-for-performance program. Everybody's getting cut. All the physicians are getting
Excuse me,
cut.
we're here to listen about C plans and plans.
Yeah.
Could we please keep the politics to yourself?
Agreed.
I don't care if you're on the left side or the right side.
Agreed.
Let's not talk politics. We all came to learn about Medicare plans.
And you're right about that, but I hear politics being
I'm not
spoken
getting
about
politics. I'm just
by
stating
the
what's in there.
presenter.
Okay, let's move on. We can talk later. Brandon, where's Brandon? Hit it. Okay. So next slide. So what we're going to do now is we're going to talk about people entering into the Medicare system. So the main thing I want you to take away from the 2013 changes and all these laws is that this change is coming. Preventative care is the new mantra. Take better care of yourself, really, is what they're trying to do. Prevent disease and so forth. So, out of everybody in this room, I'm assuming the large majority are going to be entering into Medicare. Is that correct? Okay, great. All right. So there's 4 parts to Medicare that you're all familiar with: Part A, Part B, Part C, and Part D. The 2 you have to concern yourself with is the Part A and the Part B, because the C and the D follow those 2 parts. To get into Part A, it's a very simple procedure. You had to work at least 40 quarters in your lifetime, or 10 years, and pay your Medicare taxes. When you turn 65, you will automatically get your Part A if you did that. If you did less than that, or you're a foreign national living in the U.S., at least 5 years, you can buy in. We're not going to talk about that too much. But essentially, work for 10 years, pay your Medicare taxes. When you turn 65, you'll get your Part A coverages because your Medicare taxes paid for it while you're working. It's pre-funded. They'll call it free, but it's not free. You paid for it in advance. That's all you did. To be eligible for premium-free, that's the Medicare term, premium-free Part A, it's on the basis of age. The person must be 65 or older, or either eligible for monthly Social Security retirement cash payments. That's basically, or you're disabled. All right. So if you got disabled and you're out 29 months, you can get Part A. If you have to buy it because you didn't have enough work experience, or you're foreign national, it's currently $451 a month for your Part A hospitalization. So to eliminate that segment here, is anybody living in the U.S. 5 years or less, or longer, who's not a U.S. citizen? No. Okay, good. So you're all going to get it if you all work 34. Next slide, Jen. Part A coverage will include, on the hospital side, semi-private room and board, operating rooms, ICUs, inpatient equipment. Next. Lab and x-ray, nursing, meals, and medications while an inpatient. That's drugs, but only inpatient. All right? It begins on the first day you turn 65. It's the first day of the month you turn 65. Unless you turn 65 on the first day of the month. And then it's the first day of the month previous to that. You follow that? Okay? So if I was born July 2nd, my Medicare will go into effect July 1st. If I was born July 1st, very good. Okay. Medicare Part A is, before I even get any further into this, all this is mathematics. That's all it is. It's just mathematical gymnastics. So we're going to just talk numbers a little bit as we go along. In Part A, here's what it boils down to. If you have a hospitalization and you enter the hospital and are considered inpatient, not hanging out in the ER, they admit you. That second, you, in this year, currently incur $1,156 deductible. If they discharge the next day, you're on the hook for $1,156. If you're there longer than 60 days, that's when you enter into the co-insurance or a co-payment phase. and you need to pay $289 per day along with Medicare. So it's a 60-day benefit period, and Part A is benefit periods, not fiscal year. If you have major medical now, you work in a calendar year. Yes, sir?
You're saying if you're in the hospital 15 days, it's 11.56.
Yeah, exactly.
That's it, it's not per day?
No, the first 60 days, you just pay $11.56, right? It really gets hairy when you stay there more than 60 days, right? Because after 60 days, you have to pay $289 per day, which in that 30-day period will add up to about $8,600. And then you hit your lifetime reserve, which is another 60 days, and then you're going to pay currently $578 per day. That'll add up to a whopping 34 and change. So you're on the hook for about, if you had the full extended, pleasure of staying in the hospital, about 44 grand. That's the real exposure, because from a risk in perspective, which is what insurance is, it's not like what the little pieces are. It's what's my total risk. No one says if my carpet gets burnt by my fireplace, what's my risk? It's what if my house burns down? It's the same thing. So your total risk under Part A is about 44 grand and change, and growing.
If you have the advantage plan, that goes away. It's like $78,000 maximum.
True. That's one of the attractive natures of Medicare Advantage, which we're going to address. Thanks for bringing that up. Yes. The thing you need
Could
to
you
know.
please repeat the questions, because those of us back here couldn't hear.
No problem. She asked, is all of this different if it's a Medicare Advantage plan? The answer is, Medicare Advantage plans are still, if you're in a Medicare Advantage plan, you're still in original Medicare. It's just that a third party, an outside company, is administering your benefits. They can deliver those benefits and lower your exposure by capping you, like this young man over here said, only have an out-of-pocket maximum. But you still benefit, you still have the same benefits as original Medicare. There's no difference in an MA plan and original Medicare as far as the benefits are going. It's how they're delivered, the cost exposure that's different, right? So I want to get a grasp on the Part A, Part B exposure first, and then we'll show you how to mitigate it. So, Part A, the bottom line is if you had a maximum stay hospital initial benefit, and the 30-day, and then lifetime reserve, about 44 grand. Next one.
Sorry, how many days?
It would be the first 60, 30, and another 60.
Excuse me.
Yes.
You're showing here your cost for 2012.
Right.
44 grand.
Right.
Your cost for 2013. It's all blanked out. Can you explain that, please?
Yeah, we didn't figure out 2013 because they never told us, because we call Medicare all the time. We didn't. They didn't tell us what the 2013 deductible would be, so I couldn't calculate it for you. But when 2013 comes around,
So hypothetically, we're done with 2012. 2013.
hypothetically, that's true, but as of today, it's November 9th. It's 2012, so that's all I can get is 2012 information. They didn't give me 2013 when I called them.
They'll tell you in
But
2014.
you could figure it's going to be the same or more. Like the Part B premiums estimated to be 109. Right? Not actually yet. Okay. Part B premium, you can buy into this coverage. Currently, it's $99.90 a month. It's a voluntary program. You don't have to take your Part B. Most people do. You'd be foolish not to, but Part B is voluntary. So you basically buy in it, and this is the premium that everybody pays when they're retired. They have Social Security income coming in. It's deducted from your Social Security. You can pay it directly, but everybody has it deducted from their Social Security. So a person age 65 who is over, who's not entitled to premium-free Part A, must do the following to get the premium to get the Part B. So that's where you have to be 5 years, pay the $451 and so forth.
Are you going to tell us how to, Part A is automatic, they automatically sign you up and whatnot. Part B is not automatic. You can tell us how to sign up for Part B?
Next slide.
Okay.
Here you go. Yes?
It's not automatic, it's going to Social Security.
No, it should be
No,
automatic.
automatic.
It should be automatic.
It's funny.
Yes,
Yep.
but I can tell you after all these years in this business, I tell everybody who's turning 65, call your local Social Security office, tell them you're turning 65 on this date, and do I need to come down for an interview? Sometimes they're like, no, don't even bother, the card just shows up. Other times you gotta go down and get an interview. It depends.
Theoretically, how soon before your birthday?
90 days.
Say when you buy it.
Right, so here's the way it works. If you're turning 65, this is the graph that you need to focus on. So if you're turning 65 in this month, let's just make this December 1. You could actually sign up early 3 months before December 1. So to get Medicare Part B and enroll in it, you have the month of your birthday, the 3 months previous to that, and 3 months after that. In other words, it's a 7-month window of opportunity, including the month of your birth. 3 before, the month of, 3 after. So if anybody's turning 65 in December, you should have signed up already. Actually, what, December, November, October, really September you should have called. That would have put you October, November, September, October, November. It should have been December 1. This is the most important thing to know about on Part B, because if for whatever reason, and you know, it's a mega entity of Medicare. It's the largest government entity in healthcare. So there's a lot going on over there. It's possible you can get, look, I've never seen it, but you should always work with this chart here. 3 months before, the month of, and 3 months after. All right? That's your initial enrollment period. So if you're turning 65, that's important. Go back one, please. If you're still working at 65 and have your Part A but didn't take your Part B yet and going to retire, that's important too, because you're going to have a special enrollment, but where is it? If you, like, say you retired, you're 68, and you didn't go and get your Part B, and you go outside of the initial enrollment period, you're going to have to wait for the general enrollment period. And this is what I see a lot of. People retire, take their COBRA, go 18 months, and COBRA doesn't count for the initial enrollment period. It disqualifies you for the initial enrollment period. People think, I'll run my 18 months on my COBRA because I have a really good plan to work. I need a bottle of water. Can I get a bottle of water, please? It's okay. They take the 18 months, so they go out 18 months, and they disqualify themselves in this cycle. And let's say they run out of COBRA, thank you, in, pick a date, October. They have to wait till January to go into what's called the general enrollment period, and then they don't become effective until July. So that's huge gap of coverage because they can't get onto Medicare because they missed their initial and have to wait for the general. So that's why if you're retiring, I don't say don't take your COBRA. You have to time your COBRA to put you within the initial enrollment period so you don't have to wait for the general enrollment period. Yes, sir.
I just went through this, and they told me, Social Security, that under special conditions, if you get terminated or you retire or something like that, you have an 8-month window from the last date of your work.
That's true.
So if you get paid thereafter, and if you don't sign up for B within that 8-month window, then you would have to pay a penalty.
That's true.
You know, when you sign up for B. But they did say if you're working and you take your retirement and you stop, or if you get terminated from your employer,
Right.
from the last date of your work, you get an 8-month window to sign up with no penalty.
That's
So-
true. But what I'm saying is, people leave their job, take the COBRA, run 18 months.
Right. Then you would pay the penalty because you've gone past that 8-month window.
Yeah. You actually disqualify yourself, and you have to wait for the general. That's the important part I want you to take away from this. Before you take your COBRA from your former employer when you're 65, think about it. You might want to just go on to Medicare. Your employer plan may have been great, like full drug coverage and all that kind of stuff, but it's a definite consideration. Go ahead, next slide. We don't really, this is for people who worked overseas for 12 months. Anybody do that? No, that's something special. Okay, Part B coverages, physician, ambulance, blood, diagnostic tests, x-rays, MRIs, durable medical equipment, emergency rooms, therapy, speech and physical, and that preventative services, which are covered, no deductible, no contract. So what's not covered under your Part B? And that's what most people go to Part C, which is the Medicare Advantage plan. Things like acupuncture, chiropractic, and dental are never covered under original Medicare. And that's why when you're looking at Part C or Medicare Advantage plans, they say, hey, we give you dental. give you acupuncture, transportation, vision. You're not going to get that under original Medicare. It's a perk, and they can do that. So right now in 2012, here's your exposure. It's the 140 calendar year deductible and 20% unlimited. It's basically that. So your Part B exposure, if you just have regular Part B and no wrap insurance, nothing that protects you, it's the 20% forever, basically, after you meet your calendar year deductible, which is going to go up, theoretically, in 2013. Those are the two main components of Medicare that you need to be aware of, the A and the B, the hospital, the doctor. I'm going to skip over Part C. Part C is not really a Medicare coverage, it's a type of Medicare coverage. Let's skip that. We're just going to talk about Part D right now. Part D is your drug plan. Original Medicare doesn't provide anything in drugs unless it's inpatient or hospice-related and things like that. So your Part D, you have to buy in. There's really two ways you get your Part D benefits, or your drug benefits. You can get what's called a PDP, or a standalone drug plan. It's just standalone. Or you can get what's called an MAPD, which we're going to discuss a little bit, a Medicare Advantage prescription drug plan. And that's what you commonly see in the marketplace, is MAPDs, because when you have an MAPD, most likely it will be a PPO design, like you were asking about, an HMO design, something like that. It's going to be some kind of networked plan. And they're always going to have the prescription drug generally, except for there's a few around that are straight what's called MAs, or Medicare Advantage only. If you have union drug benefits, and when you retire they say take the drug, don't take the medical, you can get a standalone Medicare Advantage and keep your union drug. Everybody follow that? But for the most part, you're going to find MAPDs in the marketplace. I'm going to actually, in this event here, I'm going to talk about a type of Medicare Advantage plan you probably will never hear about except for here. That's the hook, get it? You with me? So you have to buy into this. These are run by private insurance companies. They bid to provide prescription drug coverage in the county where you live, and every year they bid, and they come in and out of the marketplace. But for the most part, if you see a prescription drug plan standalone that's been here, it's going to always be here because they've got that business is down. They know exactly what's happening. So very few companies go out of the prescription drug business, but you will see a lot of companies getting out of the MAPD business. A lot of you probably have a plan, based on my conversation with them, that they sent you a letter. They said, hey, you know what? We're not going to do this anymore. Because they have the right every 12 months on the annual renewal. They can either stay in the county or not. In this particular case, most of the time, if you buy a standalone prescription drug plan, it's going to be there every year. Go ahead, next one. Oh, go to the next one. This is an important aspect of PDPs, or prescription drug plans. You only need one part of Medicare, A or B. Keep that in mind, A or B only. Medicare Advantage plans, you have to have A and B. Very important point. So if you have just Part A, you can get a standalone drug plan. You don't have to have the B. Or if you have Part B, you could. That's the important aspect. Go ahead, next one. Medicare Advantage plans are usually HMO or PPOs, and I'm going to explain how they work in a second, but they'll include your Part A benefits, your Part B coverage, your prescription drug coverage, which is your Part B, through that single plan. Medicare Advantage plans with prescription drug coverage are sometimes called MAPDs. So you have to have the Part A and the B to join a Medicare Advantage prescription drug plan. Okay. The other thing that's important about prescription drug, whether it's part of a PDP or an MAPD, is the formulary. That is the most important factor in your decision making when you think about your drug benefit, because every plan develops a formulary. Under the CMS rules, they have to have at least 2 drugs in each therapy, therapeutic, whatever they call it. They have to have 2 drugs for every condition, basically. But some companies say, hey, we're going to just cover all drugs. It's what we call an expanded formulary. We cover the basics and then all the designer stuff. Some plans are geared towards just the basics. They only cover the minimum amount required by Medicare. Why are they doing that? they're basically structuring their plan for pricing purposes. If they're covering, as an example, you have cholesterol, you can take simvastatin, pravastatin, Lipitor, all those drugs. Some plans don't cover Lipitor. It's a brand name. They don't want to cover. They just want to cover the simvastatin. So they gear their program or their formulary towards that type of consumer, people who are just taking generics. Other plans gear their formulary towards the person who only wants to take brand name. So you have to look at the formulary very, very carefully and make sure that your drugs that you need, if you're currently taking them, are in your formulary. You can appeal a plan. As an example, let's say I'm taking Lipitor, and I go to a new plan, and it doesn't cover it. I can appeal it. They have to give me a 30-day supply. And on my appeal, I can say, hey, can you bring it in? Because I can't tolerate the generic. They can say yes or no. If they say yes, great. If they say no, and I've joined that plan, I'm stuck with it. Now what do I do, right? So looking at your formulary is the most important thing when you're looking at your drug benefits. It's not in the formulary now. Don't assume it will be. It could come in, but that's important. All drug plans follow a standard formulary standard design of the benefit package. But when you look at a prescription drug plan, like if you go to like a drug finder on the web or however you're going to do it, they can change this up. For example, under a standard plan, under the rules, they have a $325 deductible. They could say no deductible. It's up to them. They could give you more, but they can't give you less than the minimum. The important thing is that your maximum catastrophic level is going to go through a donut hole period. I did the math here for you, basically, but here's the way it's going to work. You have you have a deductible of $325, which is the first component. That's what you pay before any drugs are covered. Then you're going to go into your initial benefit limit, and you're supposed to be paying you pay a 25% co-payment for the first $2,930 in covered drugs, which means you pay $650, $250, and the drug company pays the difference. And then you're going to go through the donut hole, the infamous donut hole. Everybody knows that term. But that's essentially where the drug plan says you're done with your initial benefits, you're on your own, keep paying until you get to the $4,750 limit combined, donut hole and initial drug coverage and deductible, and then you go into the catastrophic phase. So there's really those four levels. There's the deductible, the initial benefit, the whole, and then the catastrophic phase. And in catastrophic, you'll see a lot of plans say in catastrophic you pay, I don't know, $5 for brand names and $2, whatever they do. You have to look at the plan. But it's really 5% co-insurance for the remainder of the year. So if you're a heavy, heavy drug user, your formulary is critical. It's absolutely important that you spend the time to really examine it, make sure, and understand this. Now what they're going to do over time, I don't know if it's the next slide, Ben, can you see it?
Excuse me, could you just clarify that?
Yeah.
I'm a little confused. You say that it's 25% for the first $29.30.
Right.
Then you say the donut hole, you pay 100% for the next $37.25.
Yeah.
So adding $37.25 to $29.30 is a lot more than where you say the catastrophic benefit
Minus,
kicks
don't
in.
add, minus.
No, don't add.
Minus.
Minus.
34 from 20, minus.
Right. The important point here you need to remember is that you're going to go through an initial benefit and then hit a donut hole. But your cap, where you hit catastrophic, like say you use, I don't know, pick a number, $20,000 worth of drugs a year, you're going to cap out at $4,750 and go to catastrophic. That's the important thing. All right? So when you're looking at a drug plan, it's important, the most important thing to take away with the drug plan is your formulary and the way they address the co-insurance on your drugs. Some plans will give you a co-payment for a drug. Some plans will pay a percentage. Like very common in a formulary to say if it's a specialty drug, you pay 33% of it, as opposed to a generic drug, you pay $4 for it. All right? So the important takeaway is just to examine your drug plan very carefully. Can you go to the next slide, Brandon?
Of what they will pay for this drug.
What drugs they will cover in their plan.
Anything not on the formulary, they do not have to.
Generally, yeah. Yeah, exactly. Now, there is some relief on the way, and I'm just going to give you a quick synopsis of what's happening here. What they're trying to do in the new legislation is close that that donut hole. And what they're going to do is essentially, if you buy a prescription drug, you get a discount on it now. So let's say you buy let's just take a brand name drug. In 2013, you paid 79% of the drug cost and they discount it. But they reversed. Yeah, they have reserved. Yeah, right. It's reversed. Sorry. But anyway, here's the important point. If the drug costs $100, you maybe pay $80 for it, but they credit against your donor hole $100. So you get this sort of phantom growth through your donor hole. You're not actually paying the full amount, but they're crediting the full amount. That's the important aspect of the way the rule works. All right. So over time, by 2020, they say they're going to close the donor hole by giving you full credit, but reducing your cost. And again, you got to. The most important thing I tell you about Part D is your formulary. Because in this business, I get calls. My drug's not in my formulary. There's nothing you can do. You can appeal, but okay. Next slide, please. Yes, in fact, we're in what's called the annual enrollment period right now, which is from October 15th to December 7th this year. You can change from plan to plan. So that's why, annual enrollment is a big time of year for Medicare Advantage plans, because essentially they're trying to get your business, and this is when you're going to move, and you go into what's called a lock-in, and you'll be not stuck with the plan, but you'll be in that plan for the remainder of next year. So the next annual enrollment is when you'll change. Here's the other important thing about what's happening with your costs of the drugs. If your incomes are in these brackets, they're going to add an additional premium. So it's a means-tested type of thing where you'll pay more if you earn more for your prescription drug plan. And if you don't enroll, this is another important one. A lot of people don't take their prescription drug plan when they turn 65 because they're healthy, they don't take any prescriptions. But if you don't take it when you're eligible and you go 12 months, well, it will impose a 1% penalty for every month you could have had your PDP and didn't take it on the national average of cost, which I just pulled up the CM website, $79.64 is what it says. So they charge you 1% per month, 12% per year as a late enrollment penalty if you don't take your PDP when you're eligible. So don't forego your PDP when you become eligible. If you don't take drugs, you still should take one because you're avoiding that penalty. Yeah, I mean, if you take no prescription, take a zero plan premium if you can find one. There may be out there, I don't know, but take a plan that doesn't charge a premium if you don't take any drugs. You're avoiding that penalty, and that's the big one. So if you go say you go 6 years, it's a big number. Also, you might want to look into these types of things. Can you get extra help? Extra help is essentially where you can get, I have a whole slide on it, but extra help is where your insurance premium is paid and your drugs are reduced in cost. But you have to qualify. This is a means-tested program. There's a lot of things like you can't have so many assets, so much income, and so forth. But you should apply for it anyway, because the worst thing they can do is what? Say, no, yeah, right. You should, if you're qualified, go into the state pharmacy assistance program. It doesn't help you when you have a PDP unless you're in your donor hole, but you should apply for it anyway. It's another state-run program. Why? Because the worst that could happen is that you don't get any benefit out of it. But if you don't apply for it and you were going to get benefit out of it, and you didn't apply, you don't get the benefit.
So it's once a lifetime.
Annual, yeah. This is a big one for people who take, like I deal a lot, because I'm in the COBRA environment, I deal a lot with people on COBRA because they have like MS, compounded drugs, and all kinds of stuff like that. If you're taking any prescription drug that's expensive, you should try and get into a pharmacy assistance program or a direct program from the manufacturer. There's lots of them. Lots of them. Virtually every drug that you can think of probably has a pharmacy assistance program if it's in a specialty environment. Like if you have MS, as an example, and you're taking a compounded drug, there's only one company in Massachusetts that makes this drug for people with MS, and they have a pharmacy assistance program that says, even though you can get it somewhere else under your drug plan, we'll give it to you if you qualify. And they have a qualification process you go through. But again, these are one of the things where you should apply. The worst they can do is say, No, right?
That's another plan by itself.
This is the direct program with the drug manufacturer.
So
Right. You know, in my practice, I try to give everybody as much advantage as you can, because, just as a crude example, I have a woman in Chicago who's got MS and moving to Denver. She's going to lose her insurance, but she needs this drug that's only made by the manufacturer in Massachusetts. I got her into this assistance program. They give her the drug for nothing, you know, in her transitional phase. It's a great thing. Why not take advantage of it? Let's see. Okay, next one. So now we're going to talk about Part C, and this is really where we're going to get into the nuts and bolts of things. Part C is Medicare Advantage plans. So when you hear the word Medicare Advantage, you're really talking about Part C, right? They were introduced in 2003, and this is right off the Medicare website, an effort by Medicare to control costs by following a managed care model of healthcare delivery. And they do it in 5 major ways. Preferred provider organizations. A lot of people had PPO plans this year. And the major reason, and you correct me if I'm wrong, the major reason for the PPO is because the network was big, but if you went somewhere where the network wasn't, you could see a doctor, right? That's why you chose the PPO. You had availability of physicians outside your network. No referrals. Right. About zero premium, right? But keep this in mind, right? This is a truism, and you can apply it in anything in life. In anything in life, bottled water, it's always the lowest possible price, the highest quality, or the best service. And in nothing that you ever get, you get all 3 at the same time. Is that true? That is as true as the day is long. Price, quality, and service, that's what it's always been about. PPOs give you quality, service. Had price is going away because they couldn't deliver it at 0. HMOs are closed environments. They're what we call a coordinated care plan. They control the environment of physicians and facilities and all the places you go. It has to be in the network because they've agreed with the provider for services on a fee schedule, how they get paid. So, for example, an HMO could do Medicare-like repricing. We pay exactly what Medicare pays. Or we want a discount of 15%. We want to reprice it below the Medicare rate so that when we get paid,